Good morning and bonjour and buenos dias to everyone. We're just going to wait another minute or two while folks join the line. So just be patient with us for a minute. Leah and Rachel, I'm getting a message from a couple people that they're having trouble with the code. I just want to verify that they have the right one. A couple of our USAID colleagues. So I'm trying to open it myself. They should be using the Z99U79, is that right?
Yes.
Okay, thank you. Yeah, I think they had the same, made the same mistake that I did, which was to grab the phone code instead of the web code at first. So we'll just wait another few seconds here, folks. Great. So with that, we'll go ahead and get started. So welcome everyone to the USAID Health Systems Strengthening Case Competition Winners Showcase. We have the privilege of hosting this today. My colleagues and I from the Health Systems Strengthening Accelerator at Results for Development have had the great privilege of organizing this inaugural case competition and hosting the showcase today. So we're really glad that all of you have joined us today. Thank you. Before we really get started, there's a couple items of logistics. So first of all, to access interpretation in French or English, please click on the white globe at the bottom of your screen and select your preferred language. Please go ahead and do that now, whether you're Francophone or Anglophone, in case someone speaks in the alternative language, so that you'll have that ready when needed. I'll just pause for a second while you find that. Also, for our Francophone audience, we are putting a link to the French version of the presentation in the chat. So if you open the chat at the bottom of your screen, Leah has just put a link in there to that French version. So please feel free to open that and you can follow along there. And then for everyone, as we go through the presentations this morning, please, we do encourage you to put your questions or comments for any of our presenters in the chat function, in the chat area. using that button at the bottom of your screen. And we will do our best to keep track of those and hopefully address, if not all of them, most of them in the Q&A session that will immediately follow each presentation. Great. So with that out of the way, we are pleased to welcome you to the Winners Showcase event for USAID's first Health System Strengthening Case Competition. Our agenda today is quite simple. We have some welcome and introductions, both mine and our USAID colleague will join us in a minute. And then I will introduce the winners. The winning teams, there are 3 of them, will then present their cases, and each team will have a 7-minute Q&A immediately following their presentation. The order of the presentations, by the way, was determined by alphabetical order of the speaker's last name, so that's the only significance of the order. Following the presentations and the Q&As, we've also set aside some time to discuss the prioritization of future learning around health systems strengthening. Okay, so with that, it is now my pleasure to introduce you to the Deputy Director of the Office of Health Systems at USAID, who will introduce this session, Jesse Joseph. Jesse, over to you.
Thanks, Nathan, and good morning, good afternoon, good evening to everyone. Thank you so much for joining today for the USAID Health Systems Strengthening Case Competition, supported by the HSS Accelerator. This was our first HSS case competition, and we were thrilled to see a range of submissions representing work from all over the world. This competition was an opportunity for USAID partners working on health system strengthening activities to showcase your work and highlight the evidence and learning being generated by HSS programs and activities. The program evidence that was submitted will contribute to our evidence syntheses under the agency's HSS Learning Agenda. The Learning Agenda is a key piece of how we implement the agency's vision for Health System Strengthening 2030. Per that vision, we're shifting our HSS focus from strengthening individual functions or building blocks of a health system to a focus on intermediate outcomes, which we define as equity, quality, and resource optimization. This includes shifting program design for HSS from one of siloed, function-specific interventions to one of systems interventions that impact multiple functions of the health system simultaneously. The HSS Learning Agenda, and I think we will paste a link to the Learning Agenda in the chat, has 6 thematic question areas. This case competition was focused on 2 of those in particular. The first is, what are the contributions of systems thinking approaches and tools to changes in health systems outcomes? And the second is, how can we successfully facilitate the institutionalization and/or implementation at scale of good practices that improve health system outcomes? What are lessons learned regarding planning for sustainability and achieving results at scale? So we're really thrilled to hear from our 3 winning cases that represent strong work in these areas. This evidence and learning will inform and improve our collective ongoing work in health system strengthening and will contribute to our efforts to strengthen the global evidence base. We hope to hold similar case competitions in the future to continue to highlight our collective HSS learning. I want to take a minute just to thank everyone who made this competition possible, from all of you who prepared submissions, to HSSA and USAID staff, to the judges who spent their time reading the cases and making their decisions. I will now turn it over to Nathan Blanchett, who is moderating. So thank you, and I hope everyone enjoys this session. Over to you, Nathan.
Thank you very much, Jesse. Great opening for us, and I think you will all see today in our three winners exactly what Jesse talked about, the sort of non-siloed, multi-function or multi-building block systemic responses to high priority public health problems. So great opening, thank you. I will also give a little bit more background and let you know that part of the process was for this competition was that we received well over 30 case submissions, as Jesse said, from around the world between April and June, conducted a review process with, thankfully, 4 expert judges who reviewed all of the cases according to a standardized rubric and discussed those and chose our 3 winners. Let me first say that that was a very difficult process to choose just 3. We had excellent submissions. We had to limit the number that we really wanted to highlight in this showcase and therefore had that judging process. But all of the submissions actually are available on our website. So I think we can put the link to that before we end today so that you can see the other submissions as well. I do want to pause here and thank our judges. So we had 4 esteemed, excellent judges who worked very hard to judge all of the applications. And they are, as you see on your screen here now, Dr. Tom Bossert, Senior Lecturer and Director, now Emeritus, of the International Health Systems Program of the Harvard T.H. Chan School of Public Health. Dr. Lizelle Lagrada-Rombois, Independent Health Financing and Governance Expert. She's the former head of executive staff at the Philippine Health Insurance Corporation. Also, Dr. Kamalia Mohammed No, Professor of Public Health and Community Medicine at the University of Cyberjaya, and she is the former head of the Primary Healthcare Section of the Malaysia Ministry of Health. And finally, Dr. Helen Saxenian, an independent health economist, formerly of the World Bank. So thank you very much to our judges. And with that, we will take a step forward to announce our winners here. Just before I do that, I want to give you a heads up that if you could all open up a tab on your browser or on your phone at menti.com, we are going to integrate some poll questions into the session today. And I think we will start with our first poll right now, actually. So let me give you a minute to go to menti.com. We may need to put that code in the chat again so folks can grab it. Okay, great. So there's the code at the top of the screen, 5398408. So if you go to menti.com and just plug that code in, you should get access to this first question. Great, so we have sustainability, donor imposed outputs, buy-in from stakeholders, building common understanding between often siloed health program areas, adherence to old policies and practices, vertical funding, getting political buy-in for big changes, reforms. Hopefully our speakers can tell us a little bit about the political context that they all found themselves in. Excellent. So I think our speakers will be looking at these and I'm sure nodding their heads at some of these barriers that they also face. So I would encourage them to maybe speak to some of these and how they, if they and how they were able to work around them. Okay, great. Let's see, I think we have one other poll question to start off with. And that is, have you seen a novel health system strengthening approach in the last 5 years that you'd like to see discussed more? In one sentence, what is that? Okay, here's one on healthcare financing broadly, maybe particularly the question of community-based health insurance. PSE, is that private sector engagement perhaps? What other approaches are folks seeing, thinking about, that they would like more discussion of? Perhaps in a future case competition and elsewhere. Collaborative improvement and learning, very important. Private sector integration. Yes, complexity aware monitoring applied to health system strengthening. Health system change being a complex process. I think many of us are grappling with that one, about how to better track, measure, know that we're making progress in the right direction amid that complexity. Indicator-based health system strengthening approaches, for example, the global benchmarking tool. Great, more on health financing. ELMIS, direct funding to local partners and organizations. Certainly a big topic among USAID's localization agenda recently. Excellent. All right. Well, thank you so much. You can keep those responses coming in and we'll be tracking those. But without further ado, let's move on to what you're all really here for, which is our 3 winning cases for this year. So I am very happy to announce that these are our 2022 winners. So the titles of the cases are Institutionalizing Evidence-Based Responsive Care for Women and Children Affected by Zika. And authors, congratulations to those authors and contributors from URC. We'll hear from one of those speakers today. The second case is Strengthening Health Systems Response to Health Emergencies in Colombia. And congratulations to that team from Apt Associates and the Local Health System Sustainability Project. And third, Auditable Pharmaceutical Transactions and Services, or APTS, a systems approach for sustainably improving pharmaceutical management in Ethiopia. Big congratulations to the team at from MSH, from the MTAPS program in Ethiopia. So we're very excited to hear from all 3 of you, and we will start now with our first case. And I am very pleased to introduce you from the URC team, Lonnie Marquez. Lonnie, over to you for your presentation. Thank you.
Thank you, Nathan. And I hope people will take a minute to look at the case competition website. I want to thank our collaborators, our team leaders in the countries that participated, and also the Office of Health Systems for this chance. And my colleague, Victor Boguslavsky, couldn't be with us today, but a shout out to Victor. Let's go on to the next slide. So before COVID, the big global health emergency that was affecting certainly the Americas was Zika. If you can think back only 6 years ago, when the Zika virus began showing up in Latin America, it really posed a great crisis for us because systems in the countries were really not prepared to deal with Zika. They had never had experience with it, to diagnose it, treat it, manage it. And because of its devastating consequences, if you remember the cases of microcephaly in infants affected by Zika, it's just a terrible impact. So at the time, health systems in Latin American and Caribbean countries didn't have any guidelines to deal with Zika. Health workers were not trained to diagnose it or manage it. And interestingly, a problem because of the sexual transmission nature of Zika, Ministry of Health supply chains didn't provide condoms in prenatal care. They only provided condoms in family planning. And so it was like a difficulty to make condoms available for pregnant women. So the Office of Health Systems project, USAID Applying Science to Strengthen and Improve Systems, or ASSIST project, managed by URC, was tasked in 2017 to apply collaborative improvement and learning methods to address this crisis in the region. And specifically, our case deals with supporting care and support for Zika-affected infants and families. And because health systems in Latin America are somewhat similar and face similar challenges with Zika, our strategy was to organize a regional improvement collaborative that would link efforts in countries to test innovations, scale up things that worked, and really make a rapid dent in improving prenatal, newborn, and Zika care. And I'm just going to talk about one of those three collaboratives that focused on those three areas. So if we can go to the next slide. So what we did is we organized a regional Zika care and support collaborative, and in the end supported over 400 improvement teams in 8 countries to do 3 things: identify children who are affected by microcephaly or congenital syndrome associated with Zika, link those children to appropriate facilities and specialists and all of the things that they needed to really to optimize their outcomes, and support these teams to provide complete and integrated care to these children and their families, including providing psychosocial support because of the devastating nature of Zika infection. So the health system strengthening aspects of this that we wanted to emphasize in our case were, one, sort of training, both done in person and virtually, and covering both quality improvement methods, but also Zika diagnosis, care and support, infant neurodevelopment, sort of all the things that systems needed to really effectively respond to this challenge. And the important part of collaborative learning is bringing teams together to share what they're learning, to share what they're doing as they test changes to improve care, making that information available to others so that they can apply that learning as well. And that's a way of really rapidly scaling up the response. And finally, providing technical support to facilitate and strengthen interinstitutional cooperation and coordination. Next slide, please. So just to show you the impact of what this intervention did, the graph on the right shows 2 lines. So we had 2 groups of countries, the original countries and then the countries who joined a little bit later. Then you can see that when this work began, our measure of outcome was the percent of infants with suspected microcephaly or congenital syndrome who received all of the appropriate care that they needed according to their age and national guidelines. And as you can see, it started out around 30% or lower. And the light blue line, which is the second group of countries that started a little bit later, the reason that it started at a high level was really because of small denominators. They were really looking at very few cases. And so once they started having more cases to deal with, their results were kind of more in line with the other countries. And I think the key impact of this intervention was by ensuring complete and integrated care for these children. It provided a very concrete example of how services could be organized in integrated networks and really leverage all of the resources in a country to provide responsive, person-centered care in a crisis. And I think the other thing those of us involved in this work recognized was that child disability, both neurological as well as physical disability, was a largely hidden issue in many countries. And the Zika epidemic really brought that out to full force. And it, despite the enormous social cost of infant and child disability, it really, the systems were not organized to effectively respond to that. Next slide, please. So the things that facilitated these results, I think first and foremost is the quality improvement approach, and particularly a collaborative improvement where you're linking the efforts of many teams in various countries. It really allowed us to learn quickly and gave us a mechanism to scale up that learning so that it could be applied in more places. I think the Office of Health System in channeling Zika funding in large measure to assist, which was an existing mechanism, which had a lot of previous experience in Latin America, that allowed for a very rapid mobilization of the support. And as I want to really thank the Office of Health Systems and the Latin America Bureau of USAID for their very effective coordination of partner inputs, both at the regional level and the country level. And it made a real difference in making this an efficient and effective response. And as part of our work in each country, we did a lot of joint planning with national authorities to really make sure that whatever improvements we were helping to introduce could be sustained in terms of ongoing support to health worker capacity development, making sure tools and guidelines were still available, and continuing to document care in medical records. Let's go to the next slide. So in terms of challenges, I think the biggest one was that in two of the countries, the impact of the program was really limited by decisions of national authorities that kind of curtailed the work and really limited what could have been done. I feel that the health emergency like Zika and COVID certainly elevates the importance of the primary healthcare model and the need to support community leaders, local providers, and community health agents to identify, locate, link, and provide follow-up care to marginalized children. If I look back on the reflecting on sort of the health system strengthening lessons, I wanted to point to three interventions that are really critical in a health emergency. The first is developing tools, and then related to that is leveraging health sector reform processes and other interinstitutional coordination mechanisms to reinforce the organization of care. And certainly we believe strongly in that quality improvement is a very effective cross-cutting health system strengthening intervention. The second HHS intervention is really this emphasizing this case management role, that is taking advantage of roles such as linkage facilitators or network coordinators to really enhance integrated care networks. And then finally, establishing strategic alliances. I think with Zika, the work that we saw, it did, because of the devastating consequences of Zika, it did mobilize a whole of society response. And so there was great willingness for public and private sector, universities, NGOs to really work together to find a way to respond to the needs of these children and families. And with that, I will stop and be happy to answer any questions.
Excellent. Thanks so much, Lonnie. Great presentation. Congratulations again to you and the team that did this important work and put together a great case for all of us to learn from. So I think you definitely touched on some of the themes that Jesse started us off with, particularly the kind of cross-cutting, multifunctional, multiple functions of a health system that you really needed to tap into to get a good response here, from human resources, different trainings, regulatory functions, different organization of providers, questions, etc. It looks like we have
a question. Yeah.
Yes, we do. So please go ahead and put your questions in the chat, and I can try to voice them a little bit. So first one here is Lonnie, what could have been done from your experience to derive better or positive decisions by the authorities to improve the impact? Great question.
Well, if you're talking about the two countries that made different decisions, I'm not sure something could have been done. Those were, in the end, political decisions of the countries. But I think one of the things that worked very well, and again, our regional approach to linking activities in various countries is we made sure that countries could have learned from their neighbors. And so having meetings and having opportunities for health authorities to interact with their colleagues in other countries and learn from what they're doing was very important. And I see a second question. Let's just voice this. How can local systems take advantage of health emergencies and proactively elevate the PHC model? You know, I think that is the key learning for us. But the climate that we're in of, a focus on universal health coverage does lend itself to really elevating that PHC model and making sure that we have the right services to meet the needs of clients at every level of the system. So I think you do have to take advantage. I think when public attention is focused on a health emergency, that is a great opportunity to introduce new approaches. And I'm happy to say that although our project is over and we're not, USAID is not working as much in Latin America as they were during the Zika epidemic. In talking with some of my former colleagues, many of the lessons and interventions, particularly with supporting quality improvement and supporting care networks, do continue.
Lonnie, thank you very much. I wanted to just make one little comment, but any further comment you want to make on this? I was really fascinated by your point on child disability. The team did not go in thinking they were designing a project to investigate or respond to that kind of issue, but a certain response, systemic response to one problem gave rise to recognition of another. And I just thought that was so actually quite typical of taking a system response, that you end up needing to grapple with other things and maybe create some new pathway. So I don't know if you want to say anything more about that, or whether you think some of the systems and processes that were put in place here will actually be carrying on for that other public health problem.
Well, certainly for child disability, both neurological as well as physical disabilities. Again, because Zika became very front and center in all of the countries, and there was a lot of public attention to it, it did help mobilize ministries of health to really act on this. And again, I'm happy to say that, things that our teams help support in their countries of developing spaces for physical rehabilitation in facilities, and just doing simple things to make sure that those services were more available. Even if you didn't have highly trained specialists, you could train frontline health workers to do certain things that would be helpful. And also the community level work to kind of educate families on what they can do to improve the outcomes of children with neurological difficulty.
Great, thank you. So maybe just one last question I see that has come in from Jesse about usable data, putting usable data in the hands of practitioners. How did stakeholders up and down react or accept that approach? Was there any resistance?
Well, the beauty of quality improvement is because if you can't measure what you're doing, you haven't done anything. So it does put a big emphasis on quantitative data. And the approach that we applied was really working with health center and health hospital workers to gather their own data. So simple measures that were common across all of the country teams. We found that you can support frontline health workers to collect that data, and they see for themselves the difference that they're making. And then complementing that with collaborative learning methods that help them learn from each other and spread what they're learning to others really scales up the impact.
Excellent. All right. Thank you so much. And thank you to those of you who put questions in the chat. That was fantastic. Okay, we're going to move on. Thank you very much, Lonnie. It's now my pleasure to introduce the Chief of Party for USAID's Local Health System Sustainability Project in Colombia, Miguel Pulido. Miguel, congratulations again to you and the team, and over to you.
Thank you so much, Nathan, and hello, everybody. I have the honor to present this case today, but I don't want to start without express my big thanks and appreciation to more than 200 healthcare workers here in Colombia that were part of the rapid response teams. The people at the Ministry of Health and Social Protection, the secretaries of Health, the USAID mission in Colombia, and of course, to my team. All of them working so hard as one team. They were heroes here in Colombia facing the COVID-19 pandemic and implementing this strategy. Next, please. The context in Colombia, at that moment in March 2020, we were facing the COVID-19 pandemic, but also a new big experience from Colombia to receive migrants from Venezuela. That was at the same time, at the same moment we were facing in the healthcare sector in Colombia, these two new big issues for our country. Colombia had the Ministry of Health and Social Protection as the big director, the maximum authority, and we also have local health authorities called health secretaries. Both of them are working with insurance company, the plan of benefit administrator, but also the integration with healthcare providers such as hospital, clinics, and health facilities. We have to work as a whole team. And the first thing at that moment was to define the roles against COVID, not only the one that we already have it. Now we have to face COVID-19 and also this wave of migrants in Colombia. And this is important because all of these actors define very clear the roles, and we start to work with these responsibilities as a one team. Next, please. Something about Colombia. This country has more than 51 million people. We are not a small country. We are not the same country. We have different weather. We have different cultures. We have different cities. We have big cities, but we have extremely rural areas. And we have to face with that at that moment of facing the pandemic. So far, at the end of August, we have more than 6 million cases of COVID. Our rate, mortality rate was around 279, and Colombia was implementing something called the National Plan of Vaccination. And during the pandemic, we continue with that strategy. So far, we have more than 89 million vaccine doses administered. But not only for Colombians, for migrants as well. You know, the strategy to face the COVID include the migrant population and also the vaccine for these people. So far, we are administering more than 600,000 doses for migrant population. The number of migrants in Colombia is around 2.5 million. This is like, for example, a new city in a new country. Next, please. challenges. Our challenges was the shortage, limit human resources available for COVID-19 emergency response. I think this was something worldwide. We don't have enough healthcare workers at that moment. Weak local institution capacity, no enough experience. I think around the world, call that countries have big experience facing pandemics. Could be something that we cannot say. In Colombia wasn't the exception. We were ready to face this pandemic. We have this connection between the national level and the local level, health institution, government, insurance. Everybody was trying at the beginning to do the best. And also the surveillance system. We need to improve the surveillance system in to face the pandemic at that moment. I think this was something important because it wasn't only to do actions without have a surveillance system. Next, please. Our intervention, the rapid response teams, the main objective was strengthening the health system to respond to current and emerging health threats, including the COVID-19 pandemic. With something important, all our strategies need the sustainability. It's not only to do things without thinking in the future. It's not only to do things without optimize resources. It's not only to do things without co-create with the whole actors. At the beginning, when we create the rapid response team, we start with 34 rapid response teams. We have in each team, one epidemiologist, one doctor, one nurse, and one nurse assistant. We start to co-create with the Ministry of Health and identify the needs in each territory. We prioritize the territory, the one that we were thinking needed the special and immediately attention. We co-create the best strategy for each territory. We start to work in the connection between the local authorities and the national authorities, but also something important, we start to create the public-private partnership in each territory. And also work with the communities. When I'm talking about communities, we start to talk with indigenous community, we start to talk with migrants, we start to talk in big cities with the main players of the healthcare sector. And something important to talk right now is like after 2.5 years, these territories continue with the strategies, without the support of the resources from us. That made a success of the rapid response thing because the territories now, they saw how important it is to have these strategies and are part of the plans at this moment without the support or without the resources or economic resources to them. We have 4 important actions. We strengthen the capacity of the human resources in public health surveillance. We also strengthen the best practices for COVID-19 prevention in each moment of the pandemic. At the beginning, we were talking about the emergency, but also then helping the territories in intensive care units, but also training the healthcare workers to take care of the patient after they were in the intensive care unit, but we start the vaccination process and now prevention process and preparing for future emergencies. We also were working with the healthcare facilities to implement the national technical guidelines for COVID-19 and future emergencies. And we create the process for each territory, taking in consideration the localization strategy for the World Health Organization, that not all the strategies can apply exactly the same in each territory in Colombia. We were doing that adaptation for each territory. Next, please. Our working photos, you can see at the beginning, we were working as an astronaut, and then we were working with masks, we work with indigenous communities. Actually, this work was so beautiful because we were doing the co-creation as the needs of each territory. Next, please, and also each stage of the pandemic. Results and impact. More than 30,000 healthcare workers and over 50,000 migrants, they receive benefits from us in training, provide technical assistance to more than 500 healthcare facilities. But something important is produce knowledge exchange in our meetings and education in each territory. That's important because this is not only in one way. The rapid response teams also learning from the territories and communities, and this double way to work together and co-create is important as one of the results. Also, the Minister of Health and local health secretaries supported by the program had a detailed route map. This is important because it's not only arrive with the strategy and then say goodbye. It's important to build and strengthen capacities in these territories. More than 11 health secretaries across the country have included an operative process with the resources associated to the rapid response teams for future emergencies. That's also important in our strategy, that now that we are moving and taking one step, they'll continue working in these strategies. Next, please. Facilitators, as I say at the beginning, the sectoral and intersectoral coordination. This was only about healthcare sector. We were working with other sectors to face the pandemic, and also working with the migrants. Create the roadmap for response to health emergency. Now Colombia have this roadmap, and again with the localization strategy, each territory have a roadmap. The knowledge of each territory, recognize the indigenous authority, respect culture and traditional medicine was something important than we were doing in this strategy, and the participation of the communities. I think that co-create and work and optimize resources and working with communities in both ways is important. Next, please. And finally, some lessons learned. First of all, sustainability. This is something in our strategy that was since day one, and these days working as a sustainability. Optimize resources is important. Establish the appropriate expectation. Don't generate false expectation in this strategy. It's a key success, because when we arrived, they had too many expectations. When the rapid response teams arrived to each territory, they were thinking that we are coming with ventilators, medicines, like doing humanitarian assistance, and we were doing technical assistance in the middle of the pandemic, in the middle of a migration wave that we never had before, but we don't generate false expectation. Being so clear and establish the appropriate expectation was something that we learned here. Collaborate and establish relationship in an emergency. It wasn't easy at the beginning to create these connections, but it was something that we did. Promote interdisciplinary teamwork. It's not only about intensive care units, it's not only about doctors, it's not only about nurses, it's about community, it's about people, human beings. Systematize the process, that was important. We start to work since day one to the systematization, and don't try then to reconstruct or to see back. No, since day one, we start to systematize the process and the map, the structure of the comprehensive planning and management model. Also, since day one, we create this. Next, please. This is the information, and thank you so much, Nathan. And over to you, Nathan.
Excellent. Thank you so much, Miguel. That was an excellent presentation. And, you know, for me, I really appreciate how the team started with where the system was, and it seemed like a very deliberate process of thinking, okay, what are the actual roles of existing actors in the system when it comes to this particular emergency we're responding to? And then let's meet them there and improve from there. So just really appreciate that aspect. We will have to move a little bit efficiently, but let me give at least a few minutes here for questions from the audience. Please feel free to type in the chat. I think you might also be able to raise your hand. My colleagues, please let me know if you see any hands raised. Jesse's got a comment here. I'll just voice. Yes, multifaceted approach with clear recognition of the various stakeholders, managing expectations and increasing capacity. Yeah, great. Okay, any questions for Miguel? Miguel, one question I had was, you talked about many system things and system functions. One thing the health economist in me didn't quite hear was much about financing. Do you have a sense of, first of all, how much did the team have to interact with the challenge of financing with this emergency response? Any thoughts on whether it raised questions about the future of financing and where the financial resources for the various actors that you described to play these kinds of roles going on in the future?
Yes, that's a good question. In Colombia, each territory is responsible of the budget in the healthcare sector. You know, the national government assigned by different system resources, and now the health secretariats and governors and mayors are taking our experience and they are including this kind of strategies in their budget. You know, we have to plan the budget 1 or 4 years ahead. Now that they are including this strategy in their budget, and in that way, this strategy can be, you know, the sustainability in the future of this strategy depend of the political decisions, technical decision for the health secretariat. But the important thing so far, 11 territories, they are already including this in the budget. The other territories, maybe they wanted, but they don't have the enough resources. They still needed trying to find resources for different sources. And that's important because our program is helping them to build public-private partnerships to support this kind of strategy as well. Not only depend on the public or external budget, also internal strategies.
Right, excellent. Okay, great. Thank you very much. Okay, so we'll keep moving here, folks. Thank you again, Miguel. And we will move to our third winning case. It's my pleasure to introduce you to the country program director for the USAID Medicines, Technologies, and Pharmaceutical Services program that are known to all of us, I think, as MTAPs from Management Sciences for Health. The country program director in Ethiopia is Hailu Tade. Hailu, thank you for joining us, and over to you.
Thank you, Nathan. Good morning, good afternoon, everyone. I would like to express my thanks to USAID, Health Systems Strengthening Health Office, USAID Washington, for the opportunity. I would also want to acknowledge MTAPs and existing and old staff of MSH who have contributed to this work. And of course, importantly also, USAID Ethiopia HSS team who have been supportive from funding to follow up and support during piloting and scale up of APTS. So I am presenting to you a work performed by the SIAPS program some 5 years ago that was funded by USAID and implemented by MSH. Next slide, please. So my presentation will cover the some backgrounds about the work, activity description. We'll see the impact and evidence, some facilitators. We'll see some challenges and conclude the presentation with lessons learned. Next slide, please. So going back 10 to 15 years ago, Ethiopian Ministry of Health has actually achieved several progresses in terms of improving primary health care, reducing maternal and child deaths. But unfortunately, there were lags in the performance of pharmaceutical management and services, which was characterized by inadequate system and tools to track information, absence of legal instruments and enforcement, poor selection and prioritization of medicines, lack of accountability and transparency, poor infrastructure and facilities, and poor pharmacy organization and workflow, which actually led to continual decline in patient satisfaction of services, absence of information for decision making, inefficient utilization of limited resources, and frequent stock out of medicines. Next slide, please. So as a result, some hospitals challenged by these various bottlenecks in the performance of the pharmaceutical services within their hospital, they actually came to MSH, USAID SAPS program, and requested for support. In fact, one of the hospitals in Amara region, Debre Marcos Hospital, was the one who were able to first identify this challenge and come requesting for support. USAID SAP's response was that to go to the hospital, conduct very comprehensive assessment of the actual situation, and come up with a comprehensive intervention that is entitled Auditable Pharmaceutical Transaction and Services, which actually is self-explanatory. It means that a type of intervention that is supported by data and information and which can be audited, and performance improvement can be monitored using the data. In fact, by the time the program was closed, the APTS was scaled up to 75 hospitals and 10 regions. Next slide, please. So by design, APTS was designed taking into consideration all the six building blocks of health systems to address the issues comprehensively, because our root cause analysis indicated gaps in various components of the health system. So we cannot really address this challenge using fragmented solutions. That's why we came up with a comprehensive solution that takes into account all health system building blocks. So in terms of engagement, for implementation of APTS, all health systems from lower level health facilities up until Ministry of Health have their own roles and responsibilities, and were highly engaged throughout the process. Facilities were responsible to do their baseline assessments, inventory taking, APTS launch, infrastructure improvements, and workforce recruitment. But the higher levels health system, particularly regional and federal level authorities, were responsible for developing and enacting legislations and designing and printing of critical tools that are required for implementation of APTS. So in essence, the approach of APTS is to use various tools, including regulations, SOPs, tools relevant to financial management, inventory control, and so on, workforce infrastructure, all of which are combined together to achieve progress in 5 result areas, including governance, effective workforce deployment and development, reliable information, efficient budget utilization, and improved customer satisfaction, all of which resulted in actually in improved access to quality medicines and services, which ends up in improved health outcomes. Next slide, please. So actually, because of its comprehensive nature and holistic approach, APTS helped to address most of the challenges that hospitals used to experience that time. So the change in pharmacy layout or infrastructure improvement, for example, addressed the inconvenience of patients by streamlining services and facilitating patient-pharmacist interactions. The improvement in medicine budget management led to optimized use of resources, allowing facilities to get more resources available for them to procure medicines needed. That improved availability. The introduction of new personnel also improved generation of data and reduced wastage by providing information for critical decision making. It also reduced the waiting time of patients because it cuts the unnecessary steps that used to be operating prior to APTS. The improved quality of service, actually medicine availability and patient convenience as a result substantially increased patient satisfaction of services provided by the pharmacy. Next slide, please. So as part of highlighting key results, if we take wastage of medicines due to expiry, you can see that data gathered from many hospitals indicated the wastage reduced substantially to below 2%. The national average wastage rate due to expiry by then was about 8%. And this is a substantial improvement in terms of saving resources. Next slide, please. In terms of improving pharmacy workforce, because of APTS, new pharmacy cadres were introduced, which include pharmacy accountants, pharmacy cashiers. These are new introduced cadres which are employed by hospitals to address the challenge. And not only that, the pharmacy workforce also increased by about 100% almost, in some of the facilities by more than 100%. This indicates that patients were served by few number of health personnel, and as a result, they have to wait hours and hours until they get the services. That becomes one of the reasons for significant waiting time and patient dissatisfaction. Next slide, please. So if you take, for instance, satisfaction of patients as a result of implementing APTS, data taken from one hospital indicates a substantial increase in patient satisfaction by taking indicators relevant to the dispensing environment, the dispensing process, the pharmacy personnel, and privacy. The average satisfaction actually increased from 40 to 94%. Next slide, please. This is a pictorial representation of how substantial transformation has been achieved because of the introduction of APTS. And you'll see that the first picture indicates services before APTS, where a crowd of people are lined up behind a small grilled window, and they have to wait and wait until they get their medicines from the pharmacist. Unfortunately, as you can see, the victims of this kind of services are usually mothers. You will see that the last queue indicates mothers with kids are waiting for, becomes the last in the queue, and they suffer a lot in terms of waiting time within the hospitals. And imagine if this mother, what kind of consultation and advice can she really get within such type of environment from the pharmacist? There is a huge risk attached to the kind of services being provided in such platforms. That's why we came up with a completely transformed design on how services are provided in hospitals. Next slide, please. So with regard to sustainability and local ownership, from the very beginning, as I indicated, the APTS engaged all relevant partners and stakeholders, some of which are actually outside of the health sector. For instance, the finance offices, the Justice Bureau, the Audit Bureau, civil service bureaus were engaged in the regions, and similar institutions at federal level. And that really facilitated the process of ownership and buy-in. And so it is legislated through federal and regional regulations. By 2016, for instance, the federal government and 10 regions actually legislated APTS through their parliaments. So APTS is included as a flagship program in both iterations of the 5-year health sector transformation plans of the Ministry of Health, and all initiatives that were supported APTS become part of the routine hospital budget. So this is completely integrated into routine services. Next slide, please. So what facilitated this process? Of course, political ownership is extremely important, because this intervention was designed through a very long consultative processes and was based on government priorities. It was really quite easy to get the political buy-in. So that was extremely important for ownership and sustainability. Stakeholder engagement, as I said, some of them outside of the health sector have been participating in the whole process of APTS, from piloting to scale up. So this is a critical facilitator. Program adaptation APTS has evolved substantially since it is a scale up. A lot of improvements has been done, depending on data and experiences learned during implementation. And APTS approach is also the very nature of APTS approach also makes it amenable for improvement, continual improvement. If you see the legislation to date and the legislation of Amara region, who first actually legislated APTS, you see a substantial difference in terms of comprehensiveness. So it's really evolved over time, and now almost achieved to reached to perfection. Next slide, please. So of course, there were several challenges, including the lack of adequate personnel, high turnover of staff, shortage of pharmacists and accountants to fill regularly opening positions, resistance to change, absence of computerized solutions for reducing the burden of manual work. We have done a lot of efforts to address some of these challenges. Some of it, really, majority of the solutions worked, but some of the challenges continued to some extent. Next slide, please. Lessons learned: cultivating participation is extremely important to create consensus. So that with a critical lesson learned. Sharing successes and inspired participation. We used to create opportunity for sharing experiences and best practices amongst health facilities, amongst regions. This really helped a lot in terms of inspiring buy-in. Promoting the success of APTS also through media and various avenues of communication was also important. Aligning technical assistance with activities with government goals is extremely important to get immediate acceptance and buy-in. Interventions that target multiple health system building blocks yield much better results than fragmented and siloed type of interventions. That's what APTS proved to us. Embedding reforms in legislations actually guarantees institutionalization and sustainability. And finally, APTS actually, we have learned that APTS a typical demonstration of the application of health system building blocks in the pharmaceutical sector. Next slide. So these were the references we used. Next slide, please. Thank you very much. Back to you.
Wow, excellent, Hailu. Thank you very much, and congratulations to you and the team for such great work. So much to be impressed by there. I'll maybe just call out the comment you made about a long consultative process being very important and yielding something very important, which was that high level political buy-in, to use that term, political support, which you even then see turning into legislation, these real sustainable changes to the system. So congratulations, thank you. We have a few minutes where we could take a couple questions. If anyone has any questions for Hailu, let me see. Feel free to either come off mute and ask or put in the chat. I think you were so comprehensive, Hailu. You've answered everyone's questions. I have one though. And I don't mean to put you on the spot. This could really apply to any of the three speakers. When we see cases like this and presentations retrospectively, I think we all, we organize those well and they tell a coherent story that is quite clear now, but I'm sure was not clear when the work started. Health systems change is complex. It cannot be predicted perfectly, and you can't design an intervention. You can't engineer an intervention perfectly at the outset. So the question then is, how did you deal with that? How did you and the team deal with that? Were there things that you had to adjust or change about the design? This is one part of the question. And then how did you know that something needed to change? So I might pose that question to you, Hailu, but I'll also turn maybe to Miguel and Lonnie to reflect on any changes that had to be made and how you knew that they were needed. Hailu, would you like to?
In fact, with regard to APTS, actually, one of the challenges we encountered during implementation and noticed as part of a surprise, in fact, was that it required a lot of labor work. It was labor intensive. It requires a lot of data capturing, aggregation, and reporting. And it happens that it takes a lot of time for pharmacists to track all information during dispensing, for instance. And later, we really identified that it has to be, and also attached to the rigorous auditing practices, there was some sort of liability actually when there is, losses as a result of, some of which could be potentially unintentional. It becomes a liability for pharmacists. So if they, for instance, come across with loss of medicines due to over dispensing, for example, or breakage, so it has to be accounted for, and that hasn't been taken care of initially by design. So we actually incorporated in the legislation to compensate for that in the subsequent legislation, not in the original legislation, in fact. That is something we have actually, as an example, what we have learned through implementation.
Excellent, thank you very much. Great example of the legislation around these programs never really being finished, but needing constant adjustment. Let me just see really quickly. Please hang on the line, everyone. We finished our presentations, but we have one important poll from information we want to gather from this audience to share with USAID. So please do stay with us for a few more minutes. We'll be ending by 9:30. Before we start this poll, let me you can keep the slide up. People can get their Menti up if it's not already. But let me just give a chance for Miguel and Lonnie, if they would like, to answer that same question about something that needed to be changed in your program, kind of how you knew that was needed. Miguel or Lonnie, would you like to go ahead? Go ahead.
Sure, I'll just say, I mean, I think having a strong learning component, using the data, but also making sure you have an iterative, adaptive management approach, because things change, so you have to apply that learning immediately.
Thank you, Miguel.
And I think that then something important is adaptation. You know, we have to respond in emergency, especially in our case, as soon as possible as we start to see that things can change. You know, we cannot be as a robot, even if we are talking about digital transformation, all this stuff, but we are not robots. The human instinct and the strategies and thinking of the situation in each territory or in each issue needs adaptation immediately. It needs to be flexible. You know, it's not only about plans and indicators, it's also to respond to the needs that we are facing at the moment.
Very well said. Thank you very much.
May I add, Nathan?
Yes,
additional
please,
point?
Yes.
Yeah.
Sure.
In due course, as I indicated in my presentation, there was a serious shortage of staff, pharmacy workforce particularly, because there was a huge need for additional personnel. So in consultation with the Ministry of Health, then what was decided was all universities that have pharmacy schools increased their intake substantially. One. Number two, another intervention is there were lower pharmacy cadre colleges for training lower level pharmacy cadres, which were closed just because there was an assumption of adequate pharmacy staff in country. They were reopened and started training personnel to cater for the increasing needs for pharmacy cadres.
Wow, that's great. Fantastic to see a response like that. Both think about the future pipeline, seeing enrollment go up in particular programs that have been identified, but also who's in the existing system right now that can be trained up to contribute more. Great. Okay, fantastic. Well, thank you all very much. We're now going to go and, you know, as we sort of all pivot toward the future, this whole case competition is really about learning. Jesse introduced us or reminded us of the USAID Health Systems Strengthening Learning Agenda. We at, I'll say on behalf of my organization, R4D, that learning agenda resonates a great deal with us. I'm sure it does for all of you in the health system strengthening community. We've got limited resources, as always, to apply to learning. And so this poll that would like to do here is about how to prioritize. We have listed, and if you go to that poll, menti.com, and enter that code, you will see we have listed, how many are there? 3, 6, 7 topics, really, which I think you'll all agree are all very important. But if you were forced to prioritize them, oh, look, I think you've already started working. Thank you. If you were forced to prioritize those, how would you do that in terms of urgency? Which of these are really most urgent for us to have additional learning on? And this is important, I think, for all of us to reflect on. It's also a practical input that we'll share with USAID as they as we structure the second year of this case competition. So I'll kind of give another minute. I'll kill another minute or two here while people finish up their answers. Let me just kind of read off the major topics since the font is quite small there. So we've got one on, well, I'll read them in order of the screen here. So far, number 1 is about pre-implementation steps that we can take to lay the groundwork for the successful future scale up or institutionalization. I thought actually we had a nice example of that from Hailu, of that he said, a long consultative phase before that work started. Second is about multi-sectoral collaboration and political economy to achieve health system development goals, understanding different approaches to those. Third, so far, unless it changes, understanding the ways in which systems thinking approaches can make a difference to improve equity, quality, and resource optimization, the 3 goals that Jesse mentioned. Fourth, really picking up on the localization agenda, documenting approaches to facilitate the localization of broader health system strengthening activities, such as creating co-creation mechanisms, space for adaptation. Fifth, understanding how to drive long-term government and partner commitment to sustaining affordable access and responsive health services. Sixth, what conditions are most suitable for the application of systems thinking. And finally, a question really focused on MURL approaches, that monitoring, evaluation, research, learning approaches, methodologies, which are most effective for understanding the long-term impact and sustainability of time-bound health system strengthening approaches. So in the time that it took me to read all those, I don't think we had a change in order. So thank you all very much for participating in that poll. And with that, I think I will, let me just check with my colleagues. That poll is completed, right? Okay, great. Thank you very much. So let me just draw us to a close here today. Thank you all very, very much for joining. I want to give special thanks to Jesse Joseph for joining us today and giving us some really great opening remarks. Thanks a lot, Jesse. And thank you for the comment. I'm just seeing your last comment in the chat. Really appreciate that. Thank you especially to Lonnie, Miguel, and Hailu. I know all of you, first of all, fantastic presentations. Thank you very much. And I know you all are part of big teams for your particular activity and at your organizations. So congratulations to your whole teams and your project. Really great work. Second, this was the first year of this case competition, and we think it was a success, but we think it could be larger and broader and capture a larger, even larger audience. We were quite happy with the response that we got in this first year, but I hope you will all spread the word. And I believe the intention is to have a second round of this and maybe future rounds. So please spread the word, and we'll hope to have even more cases to judge next year. And hopefully we'll all see each other in around a year from now and learn of some great additional cases. Thanks again to our 4 judges who helped make this competition real and really quite rigorous. I hope you all took note that unfortunately R4D did not have any winning cases this year, but we're coming. So let's all, this is really fun, and it's great to learn with all of you. So thank you very much, and I hope you all have a great day. For those of you who are joining the Health Systems Research Symposium in Bogota, either virtually or in person, I'm looking forward to that. I'll be in Bogota. Reach out, and I hope to see at least some of you. Miguel, we're expecting you to host all of us, okay?
You are more than welcome here.
Muchas gracias.
Okay.
Okay. Thank you all, and goodbye.
Thank you. Thank you. Bye.
Bye.